Good afternoon. Welcome and thank you for joining the Pincus Family Foundation and four of our partners in this keynote presentation by Dr. Steven Nicklaus, Toward a Better Future: How to Leverage Strategic Partnerships to Promote Child Well-Being and Health Equity. I am Dr. Andrew Epstein, a founding trustee of the Pincus Family Foundation. Over the next few minutes, my task is to introduce you to the foundation, our partners in healthcare, and my fellow trustee and today's distinguished speaker, Dr. Steven Nicklaus, without taking too much of his time. The Pincus Family Foundation was established in the estate of David N. Pincus, a Philadelphian who was a passionate philanthropist. Since he was my uncle, I experienced this firsthand. My first memory was in the 1980s. He was galvanized to action when he saw the Philadelphia Inquirer's two-page article about the famine in Ethiopia. Over the next 25 years, he was deeply engaged in learning firsthand about the challenges to children's well-being in tragic settings of war, famine, drought, pandemic illness, and political upheaval. David had a very clear notion of philanthropy. He didn't just write checks, he got involved. His birthday present was an extended trip, a mission really, to the most ravaged regions, often with partner NGOs and with Elie Wiesel. The founding trustees and executive director adopted his mission, the well-being of children, and his character of engagement and collaboration. The foundation supports organizations and programs promoting children's health, education, safety, nutrition, recreation, and the arts. This capstone presentation follows a day-long partnership symposium, a full year in planning and design, coordinated by our partners at Temple University, sponsored by Pincus Family Foundation, and an example of our involvement with our grantee partners. We have four important commitments in healthcare and health professions education that focus on the well-being of children. First, the David N. Pincus Global Health Fellowship at Children's Hospital of Philadelphia. It was established by David in 2009 and places pediatric fellows in Botswana and the Dominican Republic. The three-year program provides a clinical, immersive, and a unique, immersive, and expertly mentored training experience that combines clinical, service, teaching, research, and advocacy to prepare Pincus Fellows to be leaders in global child health. Dr. Andrew Steenhoff is the director of the David N. Pincus Global Health Fellowship at CHOP, an associate professor of pediatrics at University of Pennsylvania. Second, the Center for Urban Bioethics in the Lewis Katz School of Medicine at Temple University. It defines and addresses health disparities as an ethical problem. This mission is realized through interdisciplinary and interprofessional educational programs, including the Pincus Urban Health Fellowship and community-engaged research into health inequities most prevalent in dense and diverse urban spaces. Dr. Kathleen Reeves, professor of pediatrics, is the center director, and Dr. Nora Jones, associate professor of bioethics, is the associate director. Third, the Center for the Urban Child and Healthy Family in the Department of Pediatrics at Boston Medical Center. Its vision is health equity, that all children have an equal opportunity to be healthy and to achieve their full potential. The center has committed to the goal that by 2028, all children cared for by Boston Medical Center Pediatrics are healthy and ready to learn with adequate supports to thrive by the age of 5. To achieve health equity, the center is building the pediatric practice of the future in collaboration with the families who are members of it. Dr. Megan Behr-Merritt is executive director of the center and professor of pediatrics at Boston University School of Medicine, and Carrie Howard is the program manager. And fourth, the Violence Prevention Institute at Tulane University School of Public Health in New Orleans brings together scholars, practitioners, and researchers across diverse fields, breaking down traditional discipline boundaries to gain new insights into the causes and consequences of violence from all perspectives, from the wiring of the brain to the family, neighborhood, and broader society. Their research, teaching, and community engagement focus on preventing and reducing violence in New Orleans and around the world. Institute leaders include Dr. Stacy Drury, Executive Director in the School of Medicine, and Dr. Samantha Francois, Executive Director in the School of Social Work. Over the past year, these 4 partners have formed a community of practice with us to plan a day-long symposium in support of shared learning, best practices, and measurable impact. We have met all day prior to this session in individual learning sessions that have produced insights in community engagement, research, recruitment, tools and methods, and fundraising, and ultimately sustainability and impact. Now we come to the closing, but first public-facing part of our symposium. I'm thrilled to introduce you to Dr. Steven Nicklaus, a founding trustee of the Pincus Family Foundation. The story of how he met David Pincus is interesting for its serendipity, but as Pasteur said, chance favors the prepared. In 1986, Dr. Nicklaus was working at CHOP, Children's Hospital of Philadelphia, as a Robert Wood Johnson General Academic Pediatric Fellow. During his fellowship, he returned weekly to Harlem Hospital to see patients in the pediatric AIDS clinic, which he had started the year before during a clinical and research gap year that gave birth to the Harlem Family AIDS Program. Meanwhile, David read a Wall Street Journal article about homeless AIDS babies in Harlem based on Dr. Nicklaus' work and called CHOP asking whether this problem also existed in Philadelphia. CHOP introduced him to Dr. Nicklaus, now in Philadelphia, and the rest, as they say, is history. The two collaborated on global health and the well-being of children for the next 25 years. A few key positions and roles from Dr. Nicklaus' distinguished CV include his leadership roles as Professor of Pediatrics and Population Health at Columbia University, Director of Pediatrics at the Harlem Hospital Center from 2000 to 2006, Director of the Program for Education and Global and Population Health at Columbia University, 2010 to 2018, and Senior Associate Dean for Admissions at the College of Physicians and Surgeons, Columbia University, 2009 to 2018. He retired in 2018 and remains active in global health through Pincus Family Foundation and other academic and not-for-profit organizations. I want to note that he reactivated his medical license in March to join the COVID response effort at Harlem Hospital. He has primarily been working with the Helping Healers Heal program, which gives peer support to frontline workers throughout the hospital. Before I turn the program over, please note that you can submit questions or comments on chat during Dr. Nicklaus' presentation, and I will serve as collector and questioner after his presentation. And now let me introduce my colleague and friend, Dr. Steve Nicklaus. His topic is Toward a Better Future: How to Leverage Strategic Partnerships to Promote Child Well-Being and Health Equity. You're in for a real treat. Steve? You'll have to unmute yourself, Steve.
Okay. Andy, thank you for that gracious introduction, and welcome everybody. Great to be with you. I want to start by thanking my fellow trustees, the staff of the Pincus Family Foundation. It's a real privilege to be working with all of you. I want to say a word about how wonderful it was to hear the discussion of the partners today. What an inspiring day you've given us. And thank you who are just joining us for this webinar. I think most of us would agree that any consideration of health equity now takes on new urgency, given the harsh glare of recent events, the COVID-19 epidemic, the worldwide recession, the recent murder of George Floyd, and so many others. We've got to put our heads together to decide how to move ahead to change the world. Well, it's now after 5 p.m. in Philadelphia, but the martinis are not yet flowing. If they were, I could regale you for hours with stories about my drinking buddy, David Pincus. As you heard from Andy, I was friends with David and his wife, Jerry, for 2.5 decades. David was a man of feeling, generosity, and patience and action. This particular moment in our history would give him great anguish. He would be ranting loudly. He could be loud about the need to do something. We've got to do something, he would say. And he's right. We've got to do something to make a healthier world for children and families. Now, given the depth of experience that I know exists amongst our partners, because I heard it all day, and the likely experience of those who are in the viewing audience, there's a risk that my talk may really be no more than singing to the choir and a little bit of bringing coals to Newcastle. But in the hope that I might add some degree of perspective that comes with having this much gray hair, I want to tell you a story. Quite condensed. Some of you may know about it, but I suspect that many of you don't. And it's about the creation of the Harlem Children's Asthma Initiative, Harlem Children's Zone Asthma Initiative, as a way to address child health disparities in Central Harlem. Now, my role in this may come as a surprise to many of you who know that I spent most of my career taking care of children with HIV and their families. But, you know, life is filled with surprises. And this unexpected project was actually one of the most fun things in my entire career, not just because of what we were able to achieve, but because of the incredibly rich tapestry of community partners we were able to bring together. So hang on for the ride, because this story involves history, some surprise twists at the end, and it will ultimately raise a central and often ignored question when we talk about the well-being of children. Whose responsibility is it? For me to frame this story, please indulge me as I give you a little bit of personal background. Yes, it's true. I'm from Wyoming. Robert Gallo, the co-discoverer of the AIDS virus, when he found out where I was from, said, "You know, until meeting you, I always thought that being from Wyoming was a myth." It's true that almost no one lives in Wyoming. When I left, the state population, which has a density of 6 people per square mile, dipped significantly. In 1981, I came to New York to start my pediatric residency. I didn't arrive on horseback, but I did arrive in cowboy boots. I lived in the predominantly Dominican community, Washington Heights, population density 90,000 people per square mile. Even though I was warned never to be the first person in a new program, I was the first resident in a new combined community pediatrics training program at Columbia. 1 resident per year. I was the beginning of an effort to create a program that hoped to become like the one in Boston, the Boston Children's Boston Medical Center Combined Residency Training Program in Pediatrics. So for the first 2 years, I trained at Babies Hospital, now called the Children's Hospital of New York, which was part of the Columbia Presbyterian Medical Center, now called the Columbia University Irving Medical Center. Here you see the relatively starchy looking but beloved group of fellow residents who included more women than men, rather, only 3 of whom were non-white. What you can't see in this picture is that I'm wearing cowboy boots, but I was wearing them. Now, just south of Washington Heights lay the famous, and in those days infamous, neighborhood, the Black community of Central Harlem. Here you can see the relative locations of Columbia Presbyterian Medical Center in the north and Harlem Hospital right in the middle of Central Harlem. Harlem Hospital was the primary source of health care for Central Harlem. It was long known to be a chaotic, poorly funded city hospital that by the 1950s was considered to be one of the worst in the city. In 1962, it became affiliated with Columbia University after pressure on all the city hospitals in New York to align themselves with major academic medical centers because of the wide recognition that care for the poor at all city hospitals was woefully inadequate. So under this affiliation contract, all doctors and research staff at Harlem Hospital were recruited, hired, and supervised by Columbia University. While there's general agreement that the quality of care and resident teaching improved dramatically, the university's relationship with Harlem had been historically strained and continued to be eyed with suspicion. And many at Columbia were less than pleased at having an association with Harlem Hospital, feeling that it detracted from its prestige. One thing the affiliation led to was some degree of reintegration of a hospital that had segregated itself as an almost totally black institution. That was after a huge fight to become integrated because it was originally a white institution. One benefit of the university's presence was a greatly strengthened capacity to create research and community-based programs in Harlem. And it was all key to the work done during the AIDS epidemic and in this asthma initiative you're going to hear about. I rotated through Harlem Hospital as a second-year resident and was there my entire third year, followed by a year as chief resident. Well, I thought I'd come for 2 years, but ultimately I'd be on staff there for 23 years, not counting the work I'm doing right now. Pediatric residency program is smaller, much more diverse than at Baby's Hospital. The director of pediatrics was Margaret Hagerty. As I would learn, she was an Irish Catholic, quite devout, a kind of mother superior in disguise, or maybe a cardinal. She frequently spoke in religious metaphors, and she once told me, by way of explaining her background, that she was the product of apostolic succession. Now, apostolic succession is a belief in many Christian denominations that since St. Peter, one of Christ's apostles, became the first bishop of Rome, there's been a linear transfer both of instruction and of grace, bishop to bishop, all the way to the present era. So when I looked at her quizzically, she explained, oh, you know, the old boys network. After graduating from medical school at Penn, Margaret Hagerty did a rotating internship at Philadelphia General Hospital, and then went to St. Christopher's to train in pediatrics under Waldo Nelson, best remembered as the editor of Nelson's textbook of pediatrics, which, by the way, is now co-edited by Joe St. Jim at CHOP. Well, Nelson was called Bill by his friends and the old man by the residents. The old man called her in and said, now, Maggie, there are almost no women professors, but you're going to be one. Well, she didn't really want to do bench research. She was interested in improving the lot of poor children. So he sent her to Harvard to work under Robert Hagerty. Not Hagerty. She was Hagerty and he was Hagerty, both Irish Catholic though. And he was at that point the director of the family health care program up at Boston Children's. Now he's the person who coined the term community pediatrics, which he explained was concerned with children who did not get adequate medical care, meaning poor children. Bob Hagerty left to become chair at Rochester, and Margaret Hagerty continued her fellowship under Joel Alpert. Alpert, of course, would later go on to Boston Medical Center. And after she finished fellowship, she then went to Cornell, created the outpatient department at New York Hospital. By the time she was in her early 40s, she had an impressive academic record, would eventually be elected to the Institute of Medicine. And just at the time that some people thought that she would take a major position in a major academic center, she surprised everyone by going to Harlem Hospital. She had long been an ardent advocate for poor children, and she said it's one thing to preach from the ivory tower about what's good for the poor. It's a whole nother to go into the community and find out if you're right. So she came asking the question, how do we take care of some of the world's poorest, sickest, and most vulnerable individuals? We know that health is affected to a large degree by the circumstances in which people are born, grow up, live, work, and age, as well as the systems put into place to deal with illness. These circumstances, in turn, are shaped by a wider set of forces like economics, social policies, politics. In the 1980s, Central Harlem was one of the most afflicted communities in the country. The confluence of poverty, community dilapidation, intravenous drug use, the AIDS epidemic, the introduction of crack cocaine and its associated gun violence, which turned the area into a war zone filled with police and SWAT units. By the mid-1980s, 10 to 15% of newborns were exposed to cocaine in utero. 10% of pregnant women had syphilis. 3 to 4% of pregnant women were HIV positive. That was the highest prevalence in the country. These circumstances drove many of Harlem's residents away. Those who could left. In the 1950s, Harlem had nearly 250,000 inhabitants, but now, after the constant decay of the infrastructure of the community, there'd been a steady exodus of over half its population, leaving an increasingly poor and desperate populace of around 100,000 people in central Harlem. I spent the first half of my career taking care of children with AIDS. You can see here the number of pediatric AIDS and cases in New York on the top. Next line is New York City, and then Harlem. At the peak of the epidemic in the early 1990s, Harlem accounted for 30% of all cases of pediatric AIDS. But then, with the advent of protease inhibitors, the so-called AIDS cocktails in 1996, the number of cases plummeted. By 2000, there were almost no more children dying from AIDS. The happiest discovery was that mother-to-child HIV transmission could be prevented. Here you see the dramatic drop in infected babies in New York moving towards elimination by the year 2000. And I could see that the New York epidemic was going to put me out of work. But what a wonderful way to become unemployed. Now, before I move on to talking about the asthma initiative, I want to take a moment to tell you about Barbara Barlow. Now, by the way, she and Haggerty got mixed up a lot. Everybody thought they looked alike. This is going to be a recurrent theme, the ladies in my life. Barlow was the first woman accepted into the pediatric surgery program at Columbia. The first woman had been accepted into the adult surgical program 50 years earlier. So pediatric surgery is really slow. And after her training, she was wooed by everybody. She surprised everybody by coming to Harlem Hospital. And so though she was a highly trained and gifted subspecialist, she had the instincts of a generalist, and for a physician with no public background training, an unusually clear understanding of the power of public health. In 1988, she started an injury prevention program that served in many ways as a template for the asthma initiative. Barbara Barlow could see with her own eyes the number of injured children coming into the emergency room and being hospitalized was increasing at an alarming rate. She knew that simply beating a drum of alarm was not going to result in the sort of help she needed. She needed data so she could apply for funding. She found Maureen Durkin, an anthropologist epidemiologist at Columbia University School of Public Health. They got a CDC grant, and they started the Northern Manhattan Surveillance Study to collect population-based data from a 4-year period. They determined through this study that the childhood injury rates in Central Harlem were the highest in the United States, way higher than the surrounding communities like Washington Heights and the South Bronx, and higher than all of New York City by far, and twice the national rate. And they saw, as they teased apart their data, there are two types of injuries. There were unintentional, many of them on playgrounds, places like that, and then, of course, intentional. There's a period where there are many more gunshot wounds and a lot of violence happening. So to address the unintentional injury, she wanted to intervene in the physical environment. Children in Harlem had no safe places to play, just the streets. City parks were in severe disrepair. They were filled with drug users, the homeless. She wanted to create safe play spaces and also conduct safety education so kids would be more savvy if they were around vehicles and in the streets. And then to address intentional injuries, which was going to be a much harder thing, she wanted to intervene in the social environment through youth mentoring and after-school activities. So she took her data and she took her ideas and she went to the Robert Wood Johnson Foundation, which gave her a grant. And so the Harlem Injury Prevention Program was born in 1988. Small core team, but what work they ended up doing. With the help of many segments of the community, from community groups to the departments of parks to fire and police departments, news media, the program grew. Over a 10-year period, 55 new playgrounds would be built. 11 city park play areas would be rebuilt. They created after-school programs in dance, art, bicycling, Little League. They brought Little League back to Harlem after years of not being there. Soccer. They conducted safety workshops. They ultimately became involved in the lives of what was estimated to be 20% of the children of Harlem. And very importantly, they evaluated the program. Over the 13-year period, child injury rates decreased by an astonishing 55% in Central Harlem, while rates in all adjacent communities and the country continued to go up. The strength of these results persuaded the Robert Wood Johnson Foundation to replicate the program, first at a handful of sites elsewhere in the country, and then nationally. And over a 20-year period from 1988 to 2008, Robert Wood Johnson provided $19 million to start and replicate the program. A national coordinating office was established at the Mailman School of Public Health at Columbia. And Dr. Barlow, who's now 82 years of age, continues to be the national director. So from these experiences, Barlow put together what she called the ABCs of injury prevention. So this is the way it actually played out. And remember that she started with not a lot of strong partners in the community. And a lot of this she just had to she didn't have much money to work with, she didn't have staff. So she really had to figure this out the hard way. So she knew she needed data before she could do anything else. So she collected the data, analyzed it. She then, looking at the pattern of those injuries, put together the coalition. Then she communicated it to Robert Wood Johnson, for example, the press. She, with her coalition, then developed and implemented the interventions, and then they evaluated the program. Well, in 2000, Dr. Hagerty retired, and despite a national search, I was the best they could come up with, and I became the next director of pediatrics. The name of the hospital still hadn't changed. It was still Harlem Hospital. But goodness, Harlem had changed. Harlem was no longer the Harlem of the 1980s. There had been a wave of renovation and building and rebuilding. Now, this picture is a signing of a bill to create the Upper Manhattan Empowerment Zone, the brainchild of Bill Clinton and Charlie Rangel, who, of course, Rangel was a long-standing chair of the House Appropriations Committee, and for many years, the most powerful politician in Harlem. Well, there's Charlie, and there's Rudy, and yes, who's that? Andrew Cuomo. He was then the Secretary of the Department of Housing and Urban Development. This federal program brought over $200 million into northern Manhattan and $1 billion in leveraged private capital, created 10,000 new jobs. As Harlem started to rebuild and so much more housing became available, some blacks began to move back. But now Harlem became integrated and the percent of blacks began to fall. So the spit and polish of all these changes really served to hide the degree of poverty that persisted then and still exists in many areas of the community. As I stepped into my new role as Director of Pediatrics, I was struck, of course, by the fact that no longer was our ICU and our wards filled with dying AIDS kids. But what really was more bothering was how many more kids there were with asthma. These were sick kids, and they were filling our wards then, which had not been true to the same degree. So no matter where I looked, I saw kids with asthma. Now, childhood asthma had always been around. As a general pediatrician, I took care of a lot of kids with asthma, but it seemed more common. And indeed, when I looked into it, pediatric asthma rates were going up throughout the country, similar trends around the world. From the little data I could scrape together, there wasn't much. It appeared that the prevalence of the disease in Harlem was around 10 to 15%. That's high. I mean, 1% of the population with anything. That's high. But still much higher than the national prevalence, which was about 5 to 8%. But I was alarmed to discover that our pediatric service at Harlem Hospital had the third highest rate in the city of children hospitalized with asthma, and the very worst record in the city of successfully treating kids in the emergency room. We treated them, sent them home, but they came back, oftentimes then getting hospitalized. I also learned that asthma was the number one reason that children miss school in central Harlem. So I needed to understand what was going on. Dr. Vincent Hutchinson did his residency at Harlem Hospital in the late 1970s. He did an allergy immunology fellowship up at Baby's Hospital, and then he came back. And by this time, he was my associate director of pediatrics, but also the director of pediatric allergy immunology. And so I said to Vince, are we doing something wrong? Is our quality of care insufficient? Now, in recent years, a lot of work had been done work had been developed by an expert panel under the aegis of the National Institutes of Health to evaluate and follow up children with asthma. There were guidelines to assess asthma severity and how to treat patients. Asthma action plans were developed so parents and older patients could prevent or control worsening asthma at home. These protocols and procedures have been demonstrated to be highly effective in middle-class kids. And we had no reason to believe that they wouldn't work for our kids in Harlem. So what were we doing wrong? So we looked very closely at our own performance on the wards, in the emergency room, in the clinics. And yeah, there was room for improvement. There always is. In particular, it was easy to be lax about doing these asthma action plans because they were time-consuming. There's never enough time for parental education. We knew that doctors oftentimes don't do a good job in this area. At any rate, we made a real effort to improve in all the areas we identified as subpar. And then performance improvement surveys showed substantial progress in those practices. So in summary, we were doing a pretty darn good job of taking care of the kids with asthma the way that we thought it should work. But despite those improvements, didn't get better. Rates of hospitalization and emergency room bounce backs did not budge. We were still failing. Now, there's a vast literature on childhood asthma, and as a generalist, I hadn't read very much of it. As I started to become familiar with it, I was amazed, and then I was amused, and then I was saddened, as I came to understand that despite a lot of talk, no one knows what causes asthma. We know genetics plays some role, but that's not well understood. People carelessly talk about things in the environment causing asthma, but we don't know that for sure. Causation is often confused with correlation. The evidence is contradictory. What is known for sure is that for children with asthma, some have wheezing that is clearly worsened by environmental triggers. Now, remember that some children with asthma don't have any demonstrable triggers. But in either case, we know a fair amount about how to treat the child with asthma who's wheezing and how to prevent wheezing. When you look at studies of the correlates of asthma severity, what strikes you immediately are the social and environmental factors such as substandard housing and triggers like dust, mold, the presence of rodents and pests like cockroaches, smoking in the home, low levels of education, literacy, low levels of literacy, low levels of knowledge about disease in general, lack of English fluency, mistrust of the medical system, and a variety of parenting factors. Now I'd like to insert here parenthetically that one of the sad things is the tendency of healthcare providers when they witness parental dysfunction to respond blamingly. What's the matter with them, they ask. But of course, wiser heads must ask about the parent who grew up in poverty. What happened to them that makes them the way they are? I had no idea how to try to address our asthma problem because it seemed clear to me the problem was out there. We did everything we were supposed to do, but the plan all fell apart as soon as the patients left our setting and returned to the community and to their homes. we came up with some ways that we thought we could give better support to families through having an on-call physician who could assist with home management and give guide parents in the use of the healthcare system in an effort to keep them out of the emergency room, for example. We did have a school health program in 12 schools, so we began working more closely with them. But I told Dr. Hutchinson that I thought we had to figure out a way to leave our comfortable domain on the wards, in the emergency rooms and clinics, and go out into the unknown. It's kind of a scary thought filled with all sorts of uncertainties. The year I became director, we at Harlem, in partnership with colleagues at Babies Hospital, are one of 10 sites nationally that were awarded 5 years of funding by the Ann Dyson Community Pediatrics Training Initiative. The primary aim of this initiative was to define a new curriculum in community pediatrics that would then become embedded in the program requirements for all pediatric residency programs. The national director of this initiative was Judy Palfrey. Now, doesn't she look like the other ladies in my life? She looks like Hagerty and Barlow, and well, anyway, she was the national director of this initiative, and she was then the chief of general pediatrics at Harvard. She'd go on, actually, to become the president of the American Academy of Pediatrics, and even later she would head up Michelle Obama's obesity initiative. We had the good luck that Judy also happened to be our site officer. The first time I met her, I mentioned our problem with asthma, and she asked if I was familiar with the Harlem Children's Zone. I said no. She then proceeded to tell me about Jeffrey Canada. Jeff Canada grew up in poverty in a tough neighborhood in the South Bronx. He was raised by a single mother among what he described as abandoned houses, crime, violence, and an all-encompassing sense of chaos and disorder. As he wrote in this book, Fist, Stick, Knife, Gun, which relates to the escalation of violence, the first rules I learned on Union Avenue stayed with me for all my youth. They were simple and straightforward. Don't cry. Don't act afraid. Don't tell your mother. Take it like a man. Don't let no one take your manhood. The book ultimately is about the destructive nature of violence on neighborhoods. Waiting for Superman is a documentary on public schools, which includes the story of Jeff Canada's creation of Promise Charter Schools in Harlem. The title derives from an interview with Canada. In it, he said, "One of the saddest days of my life was when my mother told me Superman did not exist. She thought I was crying because it's like Santa Claus isn't real. I was crying because no one was coming with enough power to save us." In the late 1970s, after going to Bowdoin on scholarship and getting a Master's of Education from Harvard, Canada began working with what then was called the Reedland Centers for Children and Families in Harlem. It was an organization that had been started to reduce truancy and improve school attendance and graduation rates. By 1990, Canada had become the president. And he looked around and decided the program just simply lacked focus. So he got to thinking. He said, what happens if we take a big part of our entire budget and use it to create a comprehensive community building initiative that focuses on the most troubled 16 square block area of central Harlem? Let's call it the Harlem Children's Zone. We have to get involved with everything in that area, everything good and bad, and make every effort to make everything bad better. Schools, preschool, pre-preschool, housing, community programs, the streets, work programs, everything we can think of. But our primary outcome to measure will be whether kids stay in school and make it from one grade to the next. If they don't get through school, what hope is there that they'll ever get out of poverty? In what has been described as one of the biggest social experiments of our time, the gamble paid off. This was the start of what has become known as the Cradle to College Pipeline program of the Harlem Children's Zone. In early 2001, at a heroes breakfast hosted by the Robin Hood Foundation, by chance, I was introduced to Jeff Canada. And goodness, what a charismatic fellow he turned out to be. When he found out who I was, he said, "Yeah, you're the director of pediatrics at Harlem Hospital. I've been meaning to give you a call. We need your help." And I felt a little dumbfounded, and I looked at him and I said, "Well, why?" He said, "Well, our formula at the Harlem Children's Zone has been working well, but in the last 2 years, we're slipping backwards because more and more kids are not making it from one grade to the next. And the reason is school absenteeism. The reason for the school absenteeism is because of asthma. So can you and your staff help us figure out what to do? We've got to do something." Well, I told him about our own challenges, and I said, "Well, you may need our help, but we need yours." And that was the beginning of the partnership. So here in this map in yellow, you can see that Zone 1, which by then was increased from 16 to 24 square blocks, but they'd already embarked on an ambitious plan where over the next 10 years, they were going to march north into what they called Northern 1 and then Northern 2. And by the time it was over, which would be 2010-11, there would be a total of 10,000 kids in this 100 square block area. Well, I began working on finding partners. Having seen Maureen Durkin's critical role in the Harlem Hospital Injury Prevention Program, the first thing I did was seek someone in public health to join us. Finding Mary Northridge was the luckiest and smartest thing I did. She was bright, both of mind and temperament. She was organized, had a huge amount of experience doing community-based participatory research. She came on very early as a lead partner. Andy Goodman was already doing asthma prevention work in Central Harlem through community groups, public schools, and health department clinics. He was a ready-made partner, as were Doris Connor in our own Central Harlem School Health Program, and Terry Marks, who had just been named supervisor of school health programs for the city. We knew about evaluation would be critical, and the Harlem Children's Zone evaluation team of Bettina Jean-Louis and Katie Shoemaker joined two of Mary Northridge's colleagues, Roger Vaughn and Linda Cushman. And finally, we hope to do some geomapping. And Mary had previously done some work around the built environment with Seth Spielman, who was over at the Columbia School of Urban Planning. So he joined our team. One of the surprise delights of the partnership that developed was the involvement of T. Barry Brazelton, probably the most famous pediatrician in the United States after Benjamin Spock, because of a TV show he had that came out of Boston. He specialized in child development, was best known for helping parents to understand the behavior of their children. Now, even though I was well along in my career by now, he taught me three important things. One, how to listen to parents rather than talk. Two, the mother is the expert, not the pediatrician. And three, for parents to accept the truth of their child's asthma, they must first mourn the loss of their normal child. How I wish I'd understood these things when I was starting my career. Robin Hood Foundation was created solely for the purpose of helping children to escape poverty. They'd never funded much in the health arena. I'd gotten a grant a few years earlier for some of my AIDS work. But I knew them to be very insistent on outcomes, but they saw themselves not just as funders, but as partners that helped you organizationally. And so we ended up getting a grant from Robin Hood. And then, thus, the Harlem Children's Zone Asthma Initiative was born. So we went after every child we could find in the Harlem Children's Zone, looking for kids with asthma. We screened anybody 12 years or younger. We went everywhere, schools, preschools, community events, baby college. Used a questionnaire, examined the kids, did peak expiratory flow rates. And lo and behold, we found the stunning prevalence of asthma, which was 25%. This was big news. And so this hit the New York Times, that the rate of asthma, childhood asthma, was the highest in the country in central Harlem. And this picture shows us at a weekend event. There's Dr. Hutchinson doing the work. There's Dr. Nicklaus tossing babies. That's prerogative of being the boss. And I got a phone call the next day, or on Monday morning rather. My phone rang, and who was it? Well, Dr. Nicklaus is Senator Hillary Clinton. Congratulations on your work. I'm very concerned about this situation. I'd like to introduce some legislation to help children with asthma. Would you and Jeff Canada join me for a press conference in Harlem? Jeff and I dutifully, sorry, I'm getting ahead of myself here. Jeff and I dutifully did the press conference, but in the press conference, Senator Clinton spent the whole time beating up on the Environmental Protection Agency and essentially suggesting the reason it was all this asthma was because the EPA was not doing their job. Of course, who was the head of the EPA was Christy Todd Whitman. And so Jeff and I looked at each other and said, what is this about? Well, end of story. Once Christy Todd Whitman left the EPA, we didn't hear anything more about childhood asthma from Senator Clinton. So what did we want to accomplish? From the beginning, it was pretty straightforward. We wanted to reduce daily and nighttime symptoms, school absenteeism, unscheduled emergency medical visits, hospitalizations. Straightforward. And we were going to put together a pastiche of interventions that were medical, psychosocial, educational, and I won't go through this whole list, but every family that enrolled a child got all of these things. So this is really for the environmental intervention in the home. Our intervention team included 2 doctors, a nurse, some pediatric residents, some students, but the real core of the team were community workers. So we called them the Harlem Air Walkers. And they went out and they found the family, they created trust, and they were the ones that really made sure that the services were provided. Now, many of our patients lived in buildings like this. This doesn't look so bad from the outside. Looks perfectly okay because Harlem's buildings were being cleaned up. But on the inside, the whole building was falling apart with leaks, mold, rodents. This mother's preparing dinner in the bathtub because it and the toilet were the only sources of water. Working with Seth Spielman, we began to do geomapping of where the children lived, the children with severe persistent asthma. And they clustered to buildings. So if you look where the large blue circle is and the red arrow, there are over 90 children in the initiative living in that area. So what this meant is that we needed to take on entire buildings rather than just single apartments. Well, luckily, Volunteers of Legal Services came into our midst at this point, and they helped provide assistance with the landlords who were very, very resistant. It's one thing for a doctor to call a landlord pleading on behalf of a patient, and that usually falls on deaf ears, but a lawyer, on the other hand, is often a quick fix for deafness. So now, finally, the slide you've all been waiting for, did it work? Well, we found for children who had an average of 3 years of services that there was a reduction and sustained reduction of daytime asthma symptoms by 55%, nighttime symptoms 46%, reduction in school absences by 69%, ER visits by 78%, hospitalizations by 83%. Decrease in dust, not much, 9%, but indoor mold exposure, 78% reduction. Home tobacco smoke exposure reduced by 81%. So just to sort of summarize this was Barbara Barlow's ABCs of injury prevention, and we did a lot of these same things, but we really had such a stronger partnership that we first A and B. So we really built the coalition, then we went after the data. And that was really our scenario. Are you seeing Dr. Ben Hutchinson there? Next slide, please. What are you seeing? Okay, next slide. Yep. Next slide, please. Yeah, good. Okay. Sorry about that. We're getting, I'm mindful of the time and I wanted to speed up just a little bit. So just let me summarize where we are right now. This was a wonderfully, joyfully successful outcome for us in this initiative. And I don't think any of us really expected it to work so well as it did. Now, for me, it was a fun run building this asthma initiative, but 6 years as director was enough. I was itching to return to AIDS work, so I stepped down and went to the Dominican Republic on a Fulbright, and Dr. Hutchinson came in, became the new director of pediatrics, and took over the lead position of the asthma initiative. Next slide. In 2008, Barack Obama announced his intention, if elected, to rebuild inner city communities by creating cradle to college programs based on the Harlem Children's Zone educational model, and he would call them Promise Neighborhoods. And when he got elected, that's what happened. Through the Neighborhood Revitalization Initiative, there were 4 rounds of funding, and there was a creation of Promise Neighborhoods. And in fact, one of them is in West Philly, and I know that Children's Hospital of Philadelphia does a great deal of work with them. I am going to end my remarks here because I'm running over a little bit. So Bruce, do you want to bring me back onto camera with Andy? Am I back on? Good? Okay. Sorry, I ran out of it. Was running over a little bit, so I'm just going to curtail the last little bit of information. And let me just close with these remarks. I want to leave you with 3 thoughts. I always say in pediatrics, there's only 4 numbers that matter, 1, 2, 3, and lots. So I'm going to leave you with 3 thoughts. The recurrent theme that you saw through this presentation is that progress is really a function of leadership. So that maybe Dr. Hagerty was onto something. Maybe there is a form of sort of spiritual apostolic succession, continuation of instruction and grace. You can certainly see that my career, throughout it, I benefited greatly from the old girls network, as it turned out. There is power in thinking like a generalist. Collaborations remove us from our safe confines. I think the hospital for many of us is the pool in which we swim and feel comfortable. But as someone once observed, the last thing a fish would be aware of is water. And finally, let me close with this thought. The person who sees only ideals accomplishes little. The person who sees only facts accomplishes even less. But the person who grasps both facts and ideals and molds the actual to the form of a vision is the person who helps to build a better world. Thank you. And now Andy's going to join me for some questions and answers and discussion.
Steve, can you hear me?
I can hear you, yeah.
Okay, perfect. Well, we do have a bunch of questions, and I know with the time, these 2 seem particularly important. One is that you built and worked with an amazing team of significant people, heavy hitters throughout this story. How do you advise those early in your careers now to start teaming up with like-minded leaders, especially those who may have power to make changes? How do you build your network, find your mentors,
Well,
and understand the levers to create this kind of change?
I think the first thing is actually embedded in the question, which is the issue of like-mindedness. If I look at my entire career, what made it work was almost never the institutions themselves. As you know, they can strengthen things, they can help create structure, protection, but oftentimes the institutions are also part of the enemies because they've got vested interests, they're self-interested, and in particular, institutions are not particularly good in supporting these sort of different experimental endeavors that are not necessarily entirely in sync with the care programs in hospitals. So I would recommend that what you do, if you're a young person in your career, is look for people who are like-minded. Get to know them, because like-minded people are looking for those with a common vision. And that common vision is helping others and being somewhat selfless in that regard. So that would be my primary. And part of it is also an affinity thing. There's no way around that. So you find somebody that you sort of resonate with, but in particular, somebody you can work side by side with on behalf of the greater good.
Yeah, I've certainly found in my own career that having mentors or being a mentor is one of the most gratifying parts of the work, and is you really stand on the shoulders of those who go before you. And I think that, first of all, knowing what levers to pull and therefore whom to go to, but secondly is just the general notion of the like-minded person who's willing to spend a little extra time with a younger professional, to mentor them, introduce them, give them some tools and so forth.
I think the other important point here is just a reminder, if you tell these stories the wrong way, like if you start at the beginning of, let's say, the Harlem Injury Prevention Program, and it's a 10-year story, and it just sounds kind of miraculous, right?
Right. Well, it feels impossible and sounds.
It feels impossible. But right. When you begin to understand, one, the heritage behind all of us, standing on shoulders, exactly the point, or apostolic succession, that we're all brought up by people who have been through a lot as well. And the other reminder is that all of these things take a long time. People want quick fixes. It's one of the problems with so many of the global health programs is that in the U.S. government funding, everybody's got ADHD. They want to get in and get out. And you can see, for Robin Hood to be told, look, if you're not going to do this for 10 years. By the way, Robin Hood, since I didn't have time to tell you the end of the story, the Harlem Children's Zone Asthma Initiative then morphed, because it almost went under. And it was changed from an academic model to really a solely community-based model. It's now in existence, it's thriving, it's doing well, 18 years later, and it's expanded its mission to all the city, so it's citywide. It's expanded to families, it's expanded way beyond asthma. And the Robin Hood Foundation is still helping to support it. It's not the sole supporter anymore, thank goodness.
Yeah. The other question that we'll have time for is one about the difficulties of getting institutional commitment, which you alluded to, but also how do you get public commitment from the government, from city buy-in, from others? Do you have to change laws, or do you have to demonstrate a tremendous benefit both socially and financially? What are some of the things that you've learned in these various efforts that can inform that approach?
Well, I think in general, if you've got to change the law to start making progress in this regard, you'll never get anything done. That's such a time-consuming thing. I think, first of all, there are different levels of law changing, but as I learned throughout my career, especially around trying to influence policy, that the way you make policy is at the grassroots level. I came into my career thinking the reverse. I thought, after I finished at CHOP, I really wanted to be a big shot. I wanted to go down to NIH, and I was offered a job down there. I thought, oh, this will be great. I'll go around in a big black car and smoke cigars and give away money and establish policy. And it was Hagerty who sat me down and said, she just laughed at me. She said, that's not the way it works. She said, The way it works is you do the work, you find the solution, and that drives everything. So you've got to have that, or you've got no legitimacy, either in the institution or out in the community. So once you've identified the problem and you've got some information, I've found that the real way to do this is there's so many people out there that are working in similar areas, and they want to know you just as much as you want to know them. But again, you got to get out of the hospital. You got to go meet people. They don't come to you. You got to go out and find them. And so that means you may have to go to community board meetings, which for me were very uncomfortable because I just stuck it. I'd go to the community board meetings in Harlem, and I'll give you one quick story of a community board meeting that I went to, and I thought, oh my, I'm just not the person to be doing this. And luckily, there was a little girl and family right in the front row, and I'd taken care of this kid, and the mother knew me. She got up and she threw her arms around me. And it was all okay.
That was it.
That was it. But so you've got to get to know people. And I think one thing, and there's a broader context here, which is about bias. Now we're in the moment of bias around skin color and all sorts of things, but there's bias at every level. There are biases against doctors. There are biases against college-educated people. There are all these different biases. It doesn't matter which domain you're talking about, proximity overcomes bias. There's a lot of data showing this. Proximity overcomes bias. Why? You get to know people. So my advice is you got to get out there and find the solution. There's no easy answer. In many ways, within the institution is harder than getting out in the community and finding partners.
Well, good. Well, listen, our time is up. I want to thank you very much for contributing these stories and your insights. And I want to thank all of the participants who have joined us for this keynote speech. Thanks very much.
Thanks, everybody, for joining us. Thank you, Andy.
Thank you, and good night.
Thank you. Good night.